Thank you for joining us today. It is March 19th, the 19th webinar of the month, and we're really excited to have Dr. Chen discussing the lymphedema surgery options and understanding your choices, or your options, shall I say. So he's making it simple. So that's actually the topic, lymphedema surgery made simple, understanding your options. And then we are also pleased to welcome Essity Jopes, who will be presenting the sponsored portion of our webinar today at the end. And they are going to generously give away an Arion Donner and gloves, and a set of gloves. So stay tuned for that. And at some point, actually, you know what? How about we can just do this right now? For those of you who are interested in receiving the Arion Donner and a set of gloves, if you can please raise your hand, because then our continuing education manager, Jennifer Williams, will start to put that into the wheel of names, and then we'll do the drawing at the end. And that way we're not, rushing at the end. That would be great. And then I would definitely like to take a moment to introduce you to my team, because they are such an important part of the NLN. So if my team can come on scene, that'd be great. Right now we have Veronica Senares. She is our social media manager. To my right on the screen, which I believe you have the same screen, is Christy Blair. She is our project manager. Below, we have our garment program manager, Alyssa Fiorito, and then there is Jennifer Williams, our continuing education manager. Also on our team, but not able to join us tonight, are Erin Sokolsky, who is our marketing manager, and also Nicole Ballard, who is our membership manager. Thank you, ladies, for everything that you do. All right, so let's see, any other? Yes, I always forget to do the disclaimer in the beginning, but I remembered today. So the disclaimer is such that, although we absolutely love Dr. Chen and everything that he does for lymphedema and lymphology and for the National Lymphedema Network, the opinions expressed in his part of the talk are those of his alone and do not necessarily reflect the position of the National Lymphedema Network. And everything that you learned from us this month and will continue to learn does not by any means replace the professional treatment and intervention that you should be receiving from your medical team, from your lymphedema therapist. All of these webinars are just meant to help you deepen your understanding of lymphedema therapy so that you can really take your self-management tasks to the next level and be inspired and really just, inspire you is really like the ultimate goal. Okay, so with that, it is now my pleasure to welcome Dr. Chen. He comes to us from the Cleveland Clinic. He is the co-director of the multidisciplinary lymphedema center at the Cleveland Clinic. He's an internationally known lymphedema surgeon who specializes in microsurgery and supermicrosurgery. And it is, my pleasure to welcome him. So Wei, if you can share your screen, share your video, we would love to see you. Thank you. Thank you so much for doing this talk for us today.
My pleasure. Happy to. Hello, everyone. All right, let me share my screen. Okay. All right. Well, thanks, Jeanette, for the introduction and the disclaimer. That reminds me to do my disclaimer. So as many of you know, that lymphedema surgery is a field of fairly advanced surgery and concepts, and therefore opinions vary depending on the surgeon you go to. As of now, there are no standards of care, and there are lots of opinions. So what I will be presenting today represents my opinion and my team's approach. So the goal of my talk today is to help you understand various surgical options and how we as lymphedema surgeon, when we consider what would be the most appropriate treatment surgery for the patient. As you know, there are various surgical procedures, how we reach that decision. So that's the main topic of today. I will try to make my talk short to leave you time for questions, and I encourage all questions related to lymphedema surgery. I have no disclosure. So lymphedema surgery starts out with knowing what you have. We need to have a confirmed diagnosis, and actually not just a confirmed diagnosis, but knowing the severity of lymphatic injury in acquired lymphedema. In primary lymphedema, the severity of underdevelopment of the lymphatic system or lymphatic hypoplasia. And then next, then having had those information, we then start to think about how we're going to treat. I've said this over and over again, that lymphedema is not and should not be a clinical diagnosis. And I think we're starting to see a paradigm shift that people used to say, and textbooks used to say, lymphedema is a clinical diagnosis. We now know that treating lymphedema as a clinical diagnosis will result in both over and under diagnosis, and also suboptimal treatment, because we need to know more than that before we start treating. So don't rely on Stammer sign, don't rely on a tape measure, but you need to have a confirmed diagnosis. More so when, for a surgeon, when we are planning on operating on a patient, we can't afford any uncertainty. We need to be absolutely certain that this is what the patient has. So what you're seeing here is what we see on ICG lymphography. That's how we can unequivocally confirm that the patient has lymphedema. And in this patient, you can see Stardust pattern in the upper arm. That's one anatomic region with linear patterns starting from hand all the way up to elbow. So that's what we call a lymphographic stage 2 disease. That's considered relatively mild, relatively early. So this patient has a favorable prognosis. So as I said, it's not just about knowing whether the patient has lymphedema or not. We also need to know both the clinical severity. Clinical severity is the symptoms that you are experiencing. You have swelling, you have skin changes, you have lymphedema fat, or you have pain and aches and rigidity, so on and so forth, numbness, paresthesia. Those are all clinical severity. And then we need to know the severity of lymphatic injury, as I have just shown, that a lymphographic stage 2 disease. And once we have these information, we're ready to treat, and we'll decide surgery or therapy, which is not the topic today. Maybe that would be another topic for another day. Pros and cons associated with therapy and surgery, and essentially they need to be carefully considered and decide what works for you. So in deciding therapy versus surgery, I think for the patient, what I usually tell my patient is actually, and I said it many times today I do my clinic, so I had this discussion with many patients already today, is first of all, what is their expectation? What are they looking to achieve? What kind of treatment outcome would they consider satisfactory? Are they happy with stopping disease progression? They're managing their current, maintaining their current condition. So they're would that be considered satisfactory, or are they looking for reversal of the pathology? And also, for example, if someone already having significant amount of lymphedema fat or lipodystrophy, we know that therapy is not going to remove lymphedema fat. So if the expectation is to remove lymphedema fat, then the patient should consider surgery. That's considered a reversal of disease, because the presence of lymphedema fat, or a clinically significant amount of it, is considered Campisi stage 3, a stage in which the patient has fluid predominant disease and without lymphedema fat. That's Campisi stage 1B. So a complete removal of lymphedema fat, downstaging a patient from stage 3 to stage 1B, that will require surgery. The next consideration is how much cost and effort cost is not necessarily money, but also physiologic cost. Is the patient willing to afford? Surgery definitely has a physiologic cost. There's recovery, there's the risk of surgery, and so both should be factored into the decision of surgery versus no surgery. So these are the currently available procedures that we offer to patients with lymphedema, and the decision making becomes a bit more complicated compared to the really early days when all we had was lymph node transfer and LVA. It was one or the other. Now there are a bunch of them, and there are debulking procedures, there are reconstructive procedures, and then there's consideration on, do you debulk first? Liposuction, for example, is a debulking procedure, and lymph vessel transplant or transfer, for example, is a reconstructive procedure. Do you reconstruct first or do you debulk first? There are a lot of discussion on that, and that I will briefly get into. But in general, we try to offer the least invasive procedure that will achieve satisfactory result. And the order of invasiveness go from top down. The lower we go, the more invasive the procedure is. So this is our treatment algorithm. We will go into each bubble, each box to explain, but you can see at the bottom that will lead to LVA, lymph vessel transfer, and in my practice, lymph vessel transfer has completely replaced, as of today, lymph node transfer, unless we uncover any data that suggests worthiness of lymph node transfer over lymph vessel transfer. Otherwise, in my practice, so far, we see no reason to perform lymph node transfer. And then liposuction and Charles procedure or radical excision. So I've already talked about initial diagnosis in addition to physical exam, 3D scanning, volumetric measurement, bioimpedance spectroscopy, quality of life assessment, ICG lymphography, which confirms the diagnosis and also stratify disease severity. We then next determine solid versus fluid predominance of disease. In the beginning, all lymphedema starts out fluid predominant. This is also the phase in which you will see lymphedema therapy being the most effective. And usually the patient would see that in the morning, their arms and legs look normal, and towards the end of the day, they get really puffy. And solid predominance is just the other way around, that the arm or leg is always big and the fluctuation now becomes small. For less experienced clinician, we can always obtain MRI or bioimpedance spectroscopy to further help us differentiate between solid predominance and fluid predominance. But for experienced clinician, usually just looking at the patient, we know already. Now, once we determine solid versus fluid predominance, those with fluid predominance would be triaged to the reconstructive arm, and the solid predominance would get triaged to the debulking arm. So in my practice, I believe that debulking first has multiple advantages, and as we have shown in our studies. So again, for fluid predominant disease, the characteristics are that the arm and legs frequently look great in the morning and they worsen during the course of the day. And this is also when we would see pitting edema. In solid predominant disease, the arm and leg are always big. They could feel firm and rigid due to subcutaneous fibrosis. The skin could be thickened if there is cutaneous fibrosis. And also, if the patient has been reporting multiple episodes of infection, usually they're already solid predominant. So one look at this patient, you don't even need to feel the leg. You know that she has solid predominance because there's already skin changes. You can see there's cutaneous fibrosis. There's also lymphedema rubor. So this patient, not only that, if you see cutaneous fibrosis, you know that there's going to be extensive subcutaneous fibrosis. So this patient would be a better candidate for debulking, not for reconstruction. So for patient who is fluid predominant, we can proceed to treat with either LVA or lymph vessel transfer. And for surgeons who are who don't like lymph vessel transfer or are not feeling comfortable with lymph vessel transfer, lymph node transfer would also work very well. In patients with solid predominant lymphedema, we prefer to treat with debulking liposuction first. If liposuction doesn't work, that's when we would offer radical excision or a Charles procedure. In vast majority of the patient, liposuction will work. So going to the boxes on the right, those would be for a patient with solid predominant disease. As I said, these patients would demonstrate non-pitting edema. And on bioimpedance, provided that they are managed well by lymphedema therapists, usually we see minimal fluid on their bioimpedance measurement. And depending on the skin quality and the severity of fibrosis, majority of the patients are treatable with liposuction, and those with severe cutaneous fibrosis and fulminant disease, then they would undergo Charles procedure. An example would be this patient, and before liposuction and after liposuction, you can see the drastic reduction in the size of the arm. This is a patient with, actually, this is not my patient. I took this patient picture off from another source. And this patient already showing sign of cutaneous fibrosis, but looking at this, I would speculate most likely liposuction was still doable, but this patient was treated with Charles procedure. And you can see Charles procedure, it is effective, but it is a morbid procedure. It is disfiguring. So we try to save this as an absolute last resort. For those with fluid predominance, depending on the severity of lymphatic injury, we would offer either LVA or lymph vessel transfer. Majority of the patients are treatable with LVA, and but those with severe lymphatic injury, namely those demonstrating diffuse pattern, lymph vessel transfer should be also part of the discussion. Now, LVA almost never completely stop working, even in those with advanced lymphatic injury. It's just that it will start to work less. It starts to become less effective. So if patients said, I still want to try LVA to see how well it works, it's fine, because LVA is so minimally invasive. And if the patient understands the limitation and wants to try it, we don't disagree with that. And lymph vessel transfer is always a backup option. So this is why LVA is so desirable. As you can see how minimally invasive they are. The procedure can also be performed under local anesthesia. Frequently patients wake up with no pain, and they it takes about 4 hours for us to usually achieve about a dozen or so connection. And most of our patients don't even take any pain medication. Some would take over-the-counter Tylenol or ibuprofen, and very few would need narcotics. And in comparison, these are the lymph vessel transfers. So lymph vessel transfer, there are 3 types. There is Dr. Koshima created the foot-based lymph vessel transfer. I prefer to do the groin-based and the lateral chest-based lymph vessel transfer. And we would do the groin-based lymph vessel transfer to for arm lymphedema. For those with leg lymphedema, we take the lymph vessel from the side of the chest. And as you can see, in distinction to lymph node transfer, there's no bump. It's just a flat patch. And this is a supermicrosurgical procedures because, again, in distinction to lymph node transfer, which is a microsurgical procedure. So this is a more refined procedure than lymph node transfer. It is also less invasive. It causes less lymphatic injury, and therefore we prefer lymph vessel transfer over lymph node transfer. So putting it together, this is our algorithm for stage 0 disease. That's, let's say, a patient following breast cancer treatment, lymph node dissection, radiation, even without swelling in the arm. That patient already has stage 0 disease. And if we perform ICG study, we would see injury. that's when we would like to offer the so-called immediate lymphatic reconstruction, which is basically LVA in patient without symptoms. And then patient with fluid predominant disease, we offer LVA for those with advanced lymphatic injury. We offer lymph vessel transfer. I no longer perform lymph node transfer. For those with solid predominant disease, we perform liposuction. Those with fulminant disease, radical excision. Following liposuction, we can then go back and offer either lymph vessel transfer or LVA, the so-called hybrid treatment. That would be currently the most thorough way of surgically treating lymphedema, debulking first and then reconstruction later. If you're interested in reading up more, all these information that I have just shared with you were published in our studies. This is our preferred liposuction technique. Well, many of you call it SAPL. I just call it lymphedema liposuction with immediate lymph contouring, the nickname flying squirrel technique. And this is our preferred, well, the so-called octopus LVA. And we don't do all the LVAs using octopus technique, but octopus technique is definitely a frequently applied option in challenging situation in patient with advanced lymphedema. We can still make LVA work using our octopus technique. And these are studies that we have put out. Actually, the one on the right just came out about our lymph vessel transfer. The one on the left was our original study. As you can see in the title, we put out the question, is transfer of lymph node still necessary? And now, at least in my practice, I don't find it necessary anymore. I certainly respect the opinions from other surgeons who still prefer to perform lymph node transfer. But in my opinion, lymph vessel transfer is a safer and equally as effective technique. This is not as relevant to you as patients, but if you are interested in how we train our super microsurgeons, we now train on Costco bought chicken thighs, so we are not sacrificing rats and mice anymore. So that's a much more humane way to train. And that's all I have. Now we'll open up for questions.
Thank you so much, Wei. I have a couple of questions myself. The first is, what is, in your opinion, the pathophysiology that can explain why lymphedema goes from fluid predominant to solid predominant? That's the first part of my question. And then the second part of this is, the solid predominant, you're referring to both adipose accumulation as well as protein, right? Or like separately, and also it could potentially be mostly fat, and it potentially can also be mostly protein. It's a question.
First part, the adipogenesis, how did that happen in lymphedema? The short answer is we don't know. There are lots of hypotheses, and if you look in the literature, there are so many hypotheses, but still, how does that come about? We don't know. It's not that lymph simply sediment and become fat. The processes are still being studied. The second part of the question is, so the solid disease component, I mean, it's really not protein, because all tissues are proteins. Our muscles are proteins, or many of the physiologic soft tissue structures involve proteins. So really the main components of solid disease, I wouldn't call it protein, it's lipodystrophy and subcutaneous fibrosis. These fibrotic tissue, which is a byproduct of chronic inflammation and lymphedema-induced lipodystrophy, these are the main component of the solid disease, the so-called solid disease component. And I mean, you hear us saying fluid predominant and solid predominant. Actually, this term predominance is a misnomer. It's just that it's easier to communicate. The fact is, even in solid predominant form of lymphedema, the fluid component is still there. So it's really more of the mixed phase. So for someone, let's say a patient with solid predominance, and the patient said, I don't care about the bulkiness, I just want to stop the disease from progressing. We can forego liposuction, we can leave the solid disease component alone and just focus on reconstructing the lymphatic system. The patient will still improve and respond to, let's say, lymph vessel transfer, although lymph vessel transfer will not touch lipodystrophy. We don't expect. So that's why I object circumference measurement as a way of tracking patient progress, because if you perform lymph vessel transfer or LVA in someone with solid predominance, the size of the arm or leg won't significantly improve, because only the fluid component will improve and the solid component will stay behind. So physiologic measurements such as ICG lymphography is a much better tracking modality.
Yeah, thank you. You know, I'd like to offer just an observation in my clinical experience of 20 years. That won't give away my age, but you know, so basically what I've observed is, you know, I've had patients where they are textbook elephantiasis, large lobules from thigh all the way down to the ankle, right? And foot as well. And even with that size, even with the duration, the long duration, because it takes a long time for that to actually occur, right? You know, the benign secondary lymphedema under normal circumstances, for it to get to that size, you know, takes many years, right? And even in those cases, those patients are able to be very amenable to lymphedema therapy, to decongestive therapy. And they are able to eventually get down to normal or near normal limb size. So with that, my theory was, or my observation is such that it's not necessarily time, right? My observation, however, for those patients who did develop, you know, over time, a greater accumulation of adiposity, are those patients who, for example, they at first had fluid predominant, they went through therapy, it responded so well, and then basically, you know, for some reason or another, they weren't able to maintain it. So then the lymphedema progressed again. They went to therapy for intensive therapy the second time. It was not as amenable to therapy this time. It was, but it took longer. It took more intervention, more creativity. Like, it just took more effort. Same thing, the patient then, you know, goes on their way, and then for whatever reason isn't able to maintain it. And now it's the third time. And now basically, whether it's the third, fourth, or fifth time, the lymphedema just doesn't respond to lymphedema therapy as well as it did the first time. So then the adipose accumulation is actually what I usually saw and observed in those cases, are those patients who weren't able to maintain it from the first time of therapeutic intervention. And then there was like this up and down with the maintenance aspect. And then I feel as though, you know, that's when the adiposity came into play. Now, I'm just sharing an observation, perhaps something to consider when, you know, you do research. But to me, the way that it kind of unfolds, it's almost like lymphedema has its own personality, right? It kind of has like its own like defensive mechanisms with like your typical protein, where, you know, you see the fibrosis, you know, getting worse over time, the skin changes. But, you know, if you didn't go through therapy the first time, it's like, it's so relieved to finally get the therapy that it's like, thank you for helping me. The skin's like so grateful, and it just basically melts with therapy. But then it's almost like if you don't maintain it, the skin and the body's kind of like, well, I thought you were helping me out. I thought you were going to give me compression, and I thought you were going to, you know that your lymphatic system is a little compromised and you're not helping me out. So then there's like this other protective mechanisms that come into play, because again, it took years for that to happen in terms of the stage 3 elephantiasis. And then all of a sudden you help it out. And then, and then if you go through these fluctuations and you don't maintain it, consistently, then the body has to develop other mechanisms, because now like the skin is like a little bit more, I don't know, I guess sensitive to like the fluctuations. And so now like the adiposity is almost like a way to, I guess, protect the soft tissues or something. I don't know. I'm not sure how to explain it, but that's just an observation. And I just wanted to see if you had any thoughts on that. Have you observed something like that?
The pathogenesis typically follows this orderly progression from fluid predominance to gradually there's mild presence of lipodystrophy. And in the old days, people described that as partially reversible swelling. And when in fact it's not swelling, that's not fluid, that's lipodystrophy. And in the past, people also used the phrase as non-reversible swelling. That's actually solid predominance. I mean, now with better understanding, we know that's not swelling. And then once the patient becomes solid, having a clinically significant amount of lipodystrophy, that's when we start to also appreciate subcutaneous fibrosis. And then gradually the subcutaneous fibrosis work its way to more superficial level, and then you develop cutaneous fibrosis. So this is the usual progression. But as we always say in medicine, patients don't read textbooks. Every now and then you'll see some outliers who don't follow this sequence. Patient who really had minimal amount of lipodystrophy, but already having cutaneous fibrosis. So they skip certain steps. I mean, that's certainly possible. We definitely have seen those cases because, as I said, patients don't read textbooks. And yeah.
Okay, thank you. Can you please elaborate a little bit more about when the Charles procedure is indicated? Like why other lymphedema surgery options are not considered? Like, just if you can just elaborate on that.
So it's actually, again, what I'm going to be saying that applies for my practice. Other surgeons may have different opinions, but I always prefer liposuction over Charles procedure, and both liposuction and Charles procedures treat solid predominant form of lymphedema. So how do I know when a patient needs Charles procedure? Well, very easy. When liposuction doesn't work, when you put the suction cannula in and you're simply not removing any tissue, the tissue doesn't want to come out because of the rigidity of the tissue. And then liposuction fail, you know, you need to do Charles procedure. Even in patients who look like they have fairly severe elephantiasis, I would attempt liposuction. But I would go into the operating room letting the patient know that there's a good chance that we may need to do Charles procedure, but we would try liposuction. If it works out, then we would do liposuction. If it doesn't, then we'll need to perform Charles procedure.
Okay, thank you. Okay, we have a whole bunch of questions in here from our audience today. The first is from Linda, and she asks, is there a surgery for excessive cording or lymphedema after sentinel lymph node biopsy, or is the procedure itself a risk for making either or both worse?
So we've never had to operate on cording. I think therapists in general have good success treating early post-operative cording, but there certainly are procedures that treat stubborn, tightly contracted scars. And as reconstructive surgeon, we do that throughout the body. One great example, similar to cording but not the same, would be the tight contracture scars for, let's say, a burn patient who was burned at the neck. And after the injury, after skin grafting, this patient's neck or chin was basically stuck to the chest. So we would classically reconstruct that by releasing the tight scar and completely resurface the wound. And there's similar situation throughout the body. In the armpit, it could be someone, again, burn injury, or could be from axillary axillary lymph node dissection radiation. Patient developed a tightly contracted scar. We would excise the bad scar and reconstruct the area, but not for cording.
Thank you. In your talk, you had talked about how the best time for the lympha procedure would be during stage 0. What are your thoughts in terms of just encouraging that plastic surgeons do that at the time of like the mastectomy?
Actually, that's more frequently how it's done. Although personally, so the classic lympha is performed at the time of lymph node dissection and in the armpit. That is not my preferred approach, and I prefer to do it later, and also not in the armpit, but in the elbow. And why that is, again, it's a long explanation. I'll give you the short version. First of all, we know that significant number of patients will recover from their lymphatic injury by themselves, just by self-healing. So if we universally operate on all patients undergoing axillary lymph node dissection, we know that for a portion of the patient, that's unnecessary surgery. That's the first reason. The second reason, I'm quite concerned about the post-operative radiation that will be done to the armpit. What that radiation will do to our delicate LVA, I think there's a good chance that the LVA might get ruined. Third, when you do LVA, you want the lymph to flow into the vein, which will require a favorable pressure gradient. Usually in the armpit, we find very juicy veins with high venous pressure. So when you hook them up, it's not uncommon we get reverse flow. But having said that, this is my opinion. The fact is, more lympha are being done in the armpit at the time of lymph node dissection than the way I do it. Again, that's my disclaimer. And there are no consensus right now. And again, I respect opinions from other surgeons also.
Thank you so much. That really clarifies a lot of things for me on that question. Thank you. Stephen asked, regarding the material on LVA, he wonders if you also use MLVA technique favored by Campisi et al. In Italy, which he understands can be more beneficial in some cases with less surgical and post-surgical scarring.
So as well as I know all the lymphedema surgeons, I'm actually not familiar what you're referring to as MLVA, but I can tell you Dr. Campisi prefers proximal LVA, which means he performed LVA fairly high up in the limb. For the lower extremity, for example, his LVA would be in the groin. We actually prefer distal LVA, and that approach is more of a supermicrosurgical approach. The proximal versus distal LVA, that is an ongoing controversy, although I think it's fair to say that more surgeons nowadays prefer distal LVA. And again, if we go into the rationale, there's a lot to be said. And I think for the time being, suffice it to say that there are surgeons performing both approaches. And in my experience, there are solid reasons and evidence why we prefer distal LVA. And I will leave it at that. I just because I really can't do justice with answer that are just a few sentences, but there's a lot that needs to be said to properly explain why we prefer the distal LVA.
Thank you. The next question is from Ashley. What are the risks associated with surgical options? With surgery, I guess.
Yeah, well, the risk really, well, overall lymphedema surgery, as I said, there are multiple procedures, not just one procedure, but lymphedema surgery overall is quite safe. It has a very favorable complication profile. There are no surgery that is 100% successful, and also surgery is not an exact science, meaning in the hands of best surgeon, the most experienced surgeons, the surgery can fail. So I think that's probably something that patients need to realize. So undergoing surgery, there are definitely risks involved. That surgery may not work and bad things may happen. As a surgeon, when we evaluate a patient for surgery, we don't just think about how much benefits the patient can get from the surgery. We also evaluate how much we can harm the patient if the surgery doesn't work, if things don't go well, if bad things happen. What can happen to the patient? And in order for us to recommend a surgery, there needs to be a favorable benefit-risk ratio. So rest assured that as surgeons, we don't just think about operating. These are things that we constantly think about.
Thank you. The next question is from Andrea. She asked, it's a question mark, compression 24/7 after liposuction. And if she already had a lymph node transfer from the neck to the calf, is she an available candidate for the other types of lymphedema surgery?
So if you already have lymph node transfer and liposuction, in our practice, that's a good amount of surgery. And usually by now, patient should have already seen good amount of changes. So if you have question, if you're considering further surgery, it means that you have question about the effectiveness of your surgery. I would suggest that you talk to your surgeon. Your surgeon most likely has a good idea whether the surgery has worked or not. And as I said, even in the best hands, most experienced surgeon, the surgery can fail. Or maybe the surgery really has worked great. It's just that you may not be perceiving it. So talk to your surgeon before you start to consider additional surgery.
Thank you, Wei. Stephen is asking if the references that you cited in your presentation, if any of them are open sources or open access.
I think some are, some aren't. But if you talk to your lymphedema therapist, they have access to medical literature. They certainly can get them for you. And if you reach out to my office here at Cleveland Clinic, I'm sure they'll be happy to help you with those studies.
Well, the question following up on that was, is it something that, and I kind of know the answer, but I'll ask it to you and I'll let you answer. Is it something that you can share with the NLN and then we post it on our website? But I'll let you answer.
So I think there are copyright restrictions that I can't do that. For journals that are not open access, I shouldn't be sharing their content, posting online. But as I said, for patients who are interested, contact your therapist or contact my office. We certainly can help you with that.
Thank you. Michelle asked, what protocol do your patients follow after liposuction in terms of wearing compression garments in order to maintain the reduction and improve flexibility in the limb?
So we bandage for a month, and then 1 month out, we transition to compression garment. The type of garment and the level of compression is always dependent on what is the least amount the patient needs to maintain containment, to maintain optimal control.
Thank you very much. Alyssa is asking, how much does a lymph vessel transfer cost if you don't have insurance? Will this help genital lymphedema as well as primary lymphedema of the legs? And will you still have to wear compression garments after surgery?
So it does work in primary lymphedema, although in primary lymphedema, we lean heavily on LVA. We try to not perform transfer procedure if possible because of the risk, more elevated risk of causing donor site problem in patients with primary lymphedema. Having said that, it does work in primary lymphedema, and we have successfully, I mean, at times when we need to resort to it, we did. How much it cost, I don't know. I really don't know. Here at Cleveland Clinic, we have our finance team who work that out with the patient. But I just know that I've been told that compared to what others are charging, our pricing is very good. And I did ask them I told them that as long as the hospital isn't losing money, I would prefer that they keep the price as low as is possible. The fact is, the lower the price, the more accessible we will make our surgery to all the patients. But I don't know.
And oh, sorry.
And there are other parts of the question that I haven't answered.
And the other one, which is also asked by Ashley, is, what are the expectations after surgery? Like, will patients still have compression stockings, and will they still have to do MLD?
So if the surgery is successful, we expect significant improvement in lymph drainage. And can the patient stop wearing compression garment? Yes, we have seen that in few patients, in small percentage of patients, but vast majority of the patient will continue to require compression. But as many of you know, compressing with a class 4 is very different from compressing with a class 2. A lot of patients are able to drop their compression requirement. A lot of patients who were previously on continuous antibiotic, because if they didn't, they develop infection, were able to stop taking antibiotic and not develop infection. So what I can tell you, so can they stop removing compression, can they stop wearing compression garment? Only few patients achieve that, but I haven't had an unhappy patient or any patient who regretted about undergoing lymphatic reconstruction that I can tell you.
Thank you. I know that what you're going to say to this is that you would refer this question to your finance team, but do you know if surgery is covered by Medicaid?
Actually, at times, yes, but Medicaid is not known to be a friendly carrier.
Thank you. For an affected limb, can more than one episode of surgery be required?
Infrequently, but yes, occasionally.
And I think you answered this already, but I'll ask it again. Can genital lymphedema or specifically male, be treated with lymphedema surgery? And if legs are also compromised, would this change the surgery?
So most frequently, penile and scrotal lymphedema are seen along with leg lymphedema. So in this situation, let's say probably one of the more common scenario is prostate cancer. And usually in this situation, both legs would be affected. So typically we would start out by treating the leg lymphedema. And when the legs are treated, the penile and scrotal lymphedema usually improve also.
Thank you. Elizabeth asked a very personal situation, which I know that you will then say you can't really, recommend it. You can't really say exactly. So Elizabeth, I'm going to ask if you can maybe reach out to Dr. Chen directly to reach out at the Cleveland Clinic, and that can be triaged a little bit more appropriately, because we won't be able to answer that specific question here in this setting. Sarah asked, consulted with another very experienced lymphedema surgeon who believes that VLNT and or LVA is most effective to address the injured lymph drainage after a SAPL, even though VLNT is more invasive and can theoretically cause donor site lymphedema. What are the specific reasons you do not do LVNT procedure anymore?
Okay, I've already addressed that in my talk, that I no longer perform lymph node transfer because now in my practice, lymph vessel transfer has already replaced lymph node transfer. And there was a time actually when I started out treating lymphedema, lymph node transfer, or VLNT that you're referring to, was the only procedure that I performed. I trained out of an institution that created lymph node transfer that was known for lymph node transfer. So it's interesting how now I don't do it anymore. But that's medicine. 15 years ago compared to now, I mean, I think it's reasonable that we do something different compared to lymph node transfer was created in 1990, and we're now in 2021. I think it's not surprising that we would do something different 30 years later.
Thank you, Wei. Janine asked, I'm not sure if this has been addressed, but is the SAPL performed first?
Well, sorry, hang on. Again, as I said in the very beginning of my talk, that there are different opinions. I'm not in a position to say others are wrong. I think we're at a phase that there are various opinions. And at this point, I mean, maybe further evidence will show up and it would prove that I'm wrong. Maybe lymph node transfer is still the better procedure. I think time will tell. At this point, as I said, I respect different opinions from all other surgeons, and what I have stated represent only my opinion.
Thank you. Just to clarify, Wade, that was just an add-on to your last, to the last question, right? Okay. So this next question is kind of like building on that. Not sure if this has been addressed, but is the SAPL performed first and then the LVA, VLNT, or the other way around?
So this is another controversy of whether to perform liposuction first, then reconstruction later, or reconstruction first, liposuction later. I prefer liposuction first and reconstruction later, although there are surgeons who like the reverse sequence.
Thank you. We still have a little bit more time. Joe, and I'll answer this also. Joe asked if you can recommend a book in terms of how to deal with a recent diagnosis of lymphedema or lymphedema treatment for dummies. And he's just been recently diagnosed 6 months ago, uses compression devices, but his healthcare team is very good, but very busy. So I'll answer it first. I'll just say, I think that, you know, there are a lot of amazing lymphedema therapists out there. And it says here that you had a quick consult with the nurse specialist. You know, nurses, and, you know, Wei, you can tell me your thoughts on this. Nurses, they typically work very closely with the medical team, with doctors, and the time that's required to perform lymphedema therapy is so extensive that it's not usually performed by nurses. It's usually performed by physical therapists, occupational therapists, massage therapists, where the entire time is, you know, billable and can be submitted to insurance. And allow me to rephrase that. The time spent on lymphedema therapy by occupational therapists and lymphedema therapists are usually reimbursed by, you know, insurance companies, not by massage therapists across the board. Sometimes it depends on the situation, the state, and everything. So allow me just to clarify that. But Wade, do you have any additional thoughts?
So I think it's never been so easy to gain access from various experts through these webinars and online meetings. There's no book that I would recommend to the patients because they're, first of all, if you read textbooks, they're quite outdated. What I'm telling you today probably will make, well, actually, some of it will make their way to textbook probably in just a few years. Some will take even longer time. So I think just from attending these webinars, you can get the most updated information.
Thank you, Wayne. The very last question is, oh, actually, there was one more in the chat, actually. We have 4 minutes left. Andrea wanted just to explain her question. She had a lymph node transfer previously, and now she wants to know, yeah, she had a lymph node transfer previously. She did not have lipo. Is she now a candidate for lipo and or other surgeries? In general.
In general, again, my opinion, other surgeons may agree or disagree. So following lymph node transfer will stimulate regeneration. And if you perform ICG lymphography, you would see these newly regenerated pathways. And that's why I prefer to perform liposuction first, because now you are, in my opinion, still a candidate for liposuction. But when we perform liposuction, we need to be very careful to not disrupt the pathways the good pathways you now have. So you can't, when liposuction is performed in view, it is in a way restricted. We need to carefully preserve the good things that have happened since your lymph node transfer. So we can't just freely treat aggressively all the lipodystrophy. But you are still a candidate. I would again advise that you talk to your lymph node transfer surgeon.
Thank you, Wei. Another question about, do you see an increased rate of cellulitis in patients after a SAPL?
No, actually, as I said, following liposuction, patients should have an improvement in lymph drainage, and that means their rate of infection, risk of infection should decrease, not increase.
Thank you, Wei. And I know you addressed this in your presentation, but perhaps I think sometimes it's just needed to be asked in a different way. And so the question is, how bad does one's lymphedema need to be in order to be considered for surgery?
So my practice is a bit different from other surgeons. I know many other surgeons would say they would only consider someone for surgery if therapy fails. That's not how I practice. I disagree with that approach just because, first of all, we're offering surgery to patients who don't even have symptoms. That would be when we perform immediate lymphatic reconstruction or lympha. So if we're offering surgery to patients without symptoms, what rationale do we have to say no to patients who are already having symptoms? That's the first reason. The second reason is if you ask therapists, how do you define failure of therapy? They would frequently tell you therapy almost never fail. And I would agree with that. Therapy almost never fail when performed properly. If you compress, fluid gets pushed out. And when you do MLD, you move the lymph. So how do you define failure of therapy? So I offer surgery. I see surgery as an equal option to lymphedema therapy. So it's not that you need to fail therapy first, then you get surgery. I think both are equal treatment options that should be presented to patient and be equally considered. They're just different. They have different advantages and limitations.
Thank you so much, Wei, for your time, for sharing your expertise, and for all the support that you give to not only the National Lymphedema Network, but the entire lymphedema community at large. Thank you so much.
My pleasure.
Okay, so it is now my pleasure to welcome Katie from SD Jobs. Forgive me, Katie. Oh, Katie Meyer. I thought I would remember your last name, but I didn't. Forgive me. Katie Meyer from SD Jobs. She is one of the medical advisors at SD Jobs, and she will be presenting the sponsored portion of today's webinar. And please do stay tuned until the end, because then we will then announce who the winner is. Thank you. Welcome, Katie. If you can just unmute yourself, that would be great. Thank you so much.
Thank you. Last time too. Hi, everyone. Like Jeanette said, I'm Katie. I'm a medical advisor for the Upper Midwest with SD Jobs. And today we're just going to talk a little bit about garments. It seems to be a hot topic as well in the questions and chat portion. So I thought I'd just go over a couple of the different custom garments that are available. I'm just going to quick share my screen here.
It would be that, oh, there you go. Excellent. Thank you.
You bet. And the little thing always covers up what I need to.
You can also do, if you go to the very bottom there on your right, you'll see it looks like 2 more over. Yeah, that one.
Thank you.
You're welcome.
A little bar on the top stops it. So, okay, excellent. So basically the first thing I wanted to go over was just being able to describe the difference between off-the-shelf stockings and custom stockings or your flat knit stockings. You know, that's a very common question of what really is the difference. So off-the-shelf stockings are circular knit stockings. They provide a high resting, low working pressure. So kind of to bring that down to an easier to understand thing, they're always really squeezing a lot. And when you move, they aren't providing an extra containment or a pressure back against the skin. They also like to go into the smallest part of the body. So as you can see with this patient, circular knit stockings, these off-the-shelf stockings, they're going to crease and go into any of the different folds that somebody might have on their leg, which can also cause discomfort or skin irritation. As opposed to, this is that same patient, but in a flat knit garment. So you can see flat knit garments, the idea behind them is to almost sort of just create like a tube that holds everything in. And truly what you're looking for primarily is containment. So something that you'll get a lot more from a custom flat knit garment is going to be containment over compression. So if you think about that, when you're thinking about garments and what maybe your therapist is recommending you to get, compared to maybe what you've bought online or something like that previously. Compression is the amount of squeeze and containment is the amount of hold. And typically to get a good hold, and that's really our goal a lot with lymphedema treatment, is to keep that fluid out of there, to contain it, to hold it. You really do have to go towards those flat knit custom garments. So Job's Elvrex. Job's Elvrex is the gold standard for flat knit garments. It is for mild to severe lymphedema, so you can use it on very mild lymphedema, but it also is able to contain up to stage 3. They offer the best in comfort and containment for the most severe, and it does bridge skin folds. So what does that mean? You know how I said circular knit garments like to sneak into those little areas, or maybe I should just say off-the-shelf garments, sneak into those little areas. Instead of doing that, a flat knit garment will just bridge that. So you'll actually see the skin go in and come out, and then there'll be a bridge of that garment holding the tissue in. Elvrex is made with a natural rubber core. We also do have latex-free Elvrex, which is called Elvrex Soft. But by using the rubber core, you're going to get the highest amount of containment that that you can get from a flat knit garment. This is just gives you an example of kind of what it looks like. It's almost like a waffle pattern. That waffle pattern, that flat knit fabric, also provides a micro massage to your skin to encourage lymph fluid movement. And then, like I said, it does bridge those areas, so it's not going to sneak into any of those skin folds. These are just some examples in regards to what lymphedema garments can look like. This is a gentleman with primary lymphedema, bilateral and genital lymphedema, and what we were able to do for him in regards to getting a custom garment. So these are really adaptable for any type of situations. And this is another example of someone with a flat knit garment. So you can see how with this type of a body shape, and what you can't see under here are the amount of folds that this person has, but you can see that it really holds everything and contains it in and can keep that fluid from really accumulating more. However, one thing that was talked on this, or one thing that was talked about during Dr. Chen's talk is after treatment that many times compression does need to be used. And depending on the level of compression that you're looking for, if your physician or your lymphedema therapist requires a high containing garment, then you're going for your Elvrex. That's what we discussed. If you're looking for compression for maintenance and it doesn't, and it still needs to be high containing, but not super high containing, there is a brand new product called Jobst Confidence that's out. And it's a wonderful brand new flat knit, and it's a 3D flat knit. And so what does that mean? It means it truly contours to your body, and it's called Jobst Confidence. The reason that we brought this out is really the elephant in the room, that 24% of patients that get garments, not are told to get garments, but that actually purchase garments, claim that they don't wear them. They bring them home and then they don't actually wear them. And there's a lot of different reasons that that can happen. These are some of the main ones, which would be, you know, new to flat knit category. Maybe it's just a little intimidating or intense to think that that's the garment that you're going to be wearing. People that need something soft, for instance, fragile skin, people with lymphedema that have sensitivity to their skin, older population, and then people that have active lifestyles. So and that's of course something that we'll always hear in any type of a compression garment, is the idea that, oh my gosh, are these going to be really hot? I hate even wearing socks, period. Are these going to be really, really warm? So our goal with this garment was to truly treat or to try and solve all of those issues that people might have with when they're going into their lymphedema garments. And so this is that Jobst Confidence. And as I said, it's that innovative knitting method that allows for high ability to conform to individual body shapes. Now, this garment is for mild to moderate lymphedema. So it's not going to be for someone that has a lot of skin folds or a very abnormally shaped limb. This will be for someone that has that mild to moderate lymphedema, or possibly, and this is something that you would discuss with your physician or your therapist, possibly that post-surgery where you may need to continue to wear compression, and a high containing compression, AKA a flat knit, you know, possibly for the rest of your life. This one allows for a much more comfortable feel while you do that. It also has moisture wicking. It's the only flat knit on the market that has moisture wicking. I love that, especially for the people down south. I mean, I'm in Minnesota, so I mean, we don't really have too much heat, to be totally honest. But for the people down south, or anyone that just has heat regulation issues or tends to sweat a lot, this helps to wick that moisture away, which is going to keep you cooler, and it's also going to provide some skin integrity help. Here's some colors, because I know that's the question we always get asked. Well, what fun colors? My favorite's the red. It's something super fun. The jeans color is also very, very popular because, let's face it, we're all wearing jeans. So that was the two main flat knits I want to discuss. This right here is a list of our medical advisors for, and I'm going to move this so that everybody can, for the United States. What I recommend is, if you have questions like things like, hey, I don't know where to get garments in my area, or maybe you need to get refitted and are wondering where a good place to get fitted for is, or looking for a recommended lymphedema therapist or anything like that, the medical advisor team is extremely knowledgeable. And so I encourage you to look through this list, possibly find where you live, and jot down the medical advisor's name and their contact information. And I can leave this up for a couple minutes while I answer any follow-up questions. But these people are a great resource for you to get information, anything regarding those garments, both daytime and nighttime garments.
Thank you so much, Katie.
You
we
bet.
really appreciate that. And you know, the one other thing that I'd like to add in terms of why patients might not wear them is because there is also the potential that it wasn't measured properly. And you know, I'd like to definitely encourage therapists who are maybe very new to lymphedema therapy, that you do not hesitate to reach out to your local rep, and they will be happy to work with you in terms of making sure that, you know, you're comfortable in measuring, because there are some, I think it's an art to measure for, you know, well, I think first of all, compression garment prescription is an art. Then measuring it measuring for custom garments is a sub-art within the art. And so I think that there's definitely a lot of considerations to consider. And so just know that there is help for you, and I encourage you to take advantage of it if you haven't. Okay. And so we do have a couple of questions. Linda has a Jobst Elverex soft seamless glove for her hand. It creases and really hurts her thumb. Might the confidence type be a better fit?
Actually, what I'd probably recommend would be to go with something called Elverex Plus. So the Elverex Plus is actually also a 3D knitted technology glove. It actually, if you were to look at one, it looks very odd because, I mean, it basically kind of looks like if you pulled your skin off your hand, it's all shaped very odd. But it's a complete 3D knitted garment for your hand. The comfort level on it is beyond anything you could possibly experience. And some of those colors also will match confidence. So if you have an arm sleeve in the flat knit, maybe it's in the Elverex Soft or the Elverex, and you want to be able to match your glove to your arm sleeve, you can match that to some of the confidence if you wanted to switch to a confidence arm sleeve, or you could match it to your Elverex that you're currently wearing too, color-wise. But that glove is beyond comfortable, and it might provide a little bit more comfort than what you've got on that one.
Thank you, Katie. Jenna asked if you can actually put that back up on the screen, like the contact information.
Absolutely.
More time with that. Thank you, Jenna. And while that's happening, oops. Oh yes, okay, great. Jane asked, is there any custom arm garment made with the majority of the fabric being cotton for patients with sensitive skin, such as those who have eczema?
You know, I don't feel comfortable answering the question in regards to eczema because I wouldn't know what your dermatologist would want against that skin. The thing about cotton, of course, there actually is cotton in our garments. But the thing about cotton to remember is that if you're looking for a compression garment, you have to have a certain amount of elastic or rubber in the garment because that's what creates the compression. So the less of that you have, if you were to add in more cotton, the less compression you would be able to have into that garment. If you, I don't know, I can't, of course, ask the patient, or maybe you want to put it in the chat, but do you wear a flat knit garment currently, and have you had bad experience wearing that flat knit? Because that would be the thing I would start with first is, what have you tried? What experience have you had wearing that type of a garment? And then we could go from there in regards to what might be recommended more. I do know that especially off the shelf sheer garments can be irritating to the skin. So if that's maybe an experience that you've had there that had, a poor reaction to the dry skin or the eczema, you may be wanting to look into something that is a different textile.
Thank you very much, Katie. Lynn has a question. Do they also do that for the toes? Lynn, I'm not exactly sure which part you were referring to. So if you can just clarify that question, and we'll be happy to answer it. Thank you so much.
My guess is probably asking about the glove 3D knit. And if that's the question, yes, it's available in a toe cap too. And it's amazing. It's very, very comfy.
Thank you. I should have asked if you knew what that could be referring to. Okay.
I don't know. I was taking a stab in the dark.
No, that sounds good. All right. Leanna would like to know if there's any medical advisor available for her in the Caribbean.
I know we have them in every country, so I would have to get back to that. And what I would actually recommend is, if you look at this list at the top there, Margie Hopkins, she's our lead. And she, if you want to take down her information, she'd be a great person to reach out to try and find, to try and get connected with that representative. Thank you. I couldn't tell you who that would be off the top of my head.
So if you say that you're everywhere, then I guess Julie from Australia will be happy then, right? Because she's asking, is the Jobst Confidence available in Australia?
Oh, that is I believe it's, I hate to say this, and hopefully one of my colleagues is going to text me right now and correct me, but I believe it's only in the US and Canada currently. We just launched it at the end of last year, and I believe it's starting here in North America. But I could be wrong. I will promise to get that information back to Jeanette so that you could push that out, feel free to take my information down here, Katie Meyer right there, and I will for sure get back to you on that.
Thank you. Jane is asking, does the Confidence have the option of a combination arm and hand sleeve in a one piece?
It will. It's part, so this just launched, like I said, in November of last year, in a knee high, a thigh high, and an arm sleeve. The gauntlet, so the combined all the way up, is, I believe, part of our launch by the end of the year, along with things like capri pants and Bermuda shorts and pantyhose and all of those other different styles. So that, yes, that will be available. It's not available currently, but it will be launched soon.
Thank you, Katie. The next question is, are your garments made in the US or in Germany?
They are made in, well, I got to hold back there. It depends on which garment you order. So our lymphedema garments are made in Germany. So that would be the Elvrex Soft Confidence, our nighttime relax garment. So although the fact that they are made in Germany, we still are able to get our garments back in 4 to 5 business days from the day that they're ordered. So the turnaround time is crazy fast for a lymphedema garment. If you're looking at our cut and sew garments, which is our custom seamed garments, those are made in North Carolina. And those are actually sewn by hand rather than knit from a knitting machine. And then our nighttime Jovi Pack garments, those are made in Seattle, Washington.
Thank you.
Welcome.
Alyssa asked, do you have garments that offer greater than 50 millimeters of mercury of compression for primary lymphedema of the lower extremity?
So that custom seamed garment that I was discussing that's made in North Carolina, that garment can actually go above 90 millimeters of pressure. 90 millimeters of mercury of pressure. So I guess it would just really depend on what you've done before. So a lot of times when I see those super high compressions, it's somebody like a primary that's been wearing compression their whole life and slowly gets more and more compression. But for sure, the custom seamed garments can go to those, extreme high millimeters of mercury of pressure compression levels.
Thank you. Stephen is asking, for the Confidence line, is it available up to class 3 strength?
Yes, it is.
Okay, great. And plus,
I should specify that's in lower extremity. In lower extremity, it's up to class 3. And the reason that we don't go all the way up to like a class 3 forte or a 4 is because if you're looking at that type of a high compression, then it's probably more appropriate that you're looking into the Elvrex because you have maybe a more severe case.
Thank you.
Oh, and I did want to clarify something on that compression level, just so that you know, we do have in our traditional Elvrex, you can get a class 4, which is set for lower extremity, which is 49 to 70 millimeters of mercury of pressure, and a class 4 super, which is 60 to 90 millimeters of pressure. So if you were looking for the flat knit in the high compressions, you can also do that too.
Thank you. Stephen would also like to know, are full designs and colors presented that you presented, are they available in Canada? As he's in Canada.
I believe the color palette is identical in Canada. I think that in Canada, now you're getting me to remember stuff. I believe the thigh high is not yet available in Canada, but will be this month. But in regards to the colors, I believe the whole color palette is the same, no matter if you're in the US or in Canada. Down at the bottom, you'll see Sophia White. Hopefully you guys can see that. That's your Canada representative. So she's the me in Canada, and she's wonderful. So I would definitely reach out to her, and she can keep you updated in regards to the times that things are launching up there and places that you can get your Confidence.
Thank you, Katie. I totally appreciate all the color choices that you offer. And I also appreciate, now tell me if this is just for the demo purposes or if it's actually offered, but you know how when you show the Job's Confidence on the for the lower extremity, that contrasted seam in the back, is that actually what you get?
So there's the contrasting seam is, well, let me actually grab one here.
Because I think it's really cool.
So there's, in Elvrex, you can have your garment and you can actually have, so any of your flat knit garments are going to have a seam. I should say any of your custom garments are going to have a seam because they knit it and then they sew it together. It's a flat seam, so it's very comfortable, but it's always going to go on the back of the leg. I don't know if you guys can see I'm going to go ahead and take this down. So you guys can see my garments better. Okay, so here's the back of the garment. You can see that seam. Now on Elvrex, you can change this seam at no cost. So you may be like, well, why would you need to do that? One, it's a little retro if you wanted it to be, but also I have people that get garments like quarterly, and they might get two every quarter or 2 every 6 months. And they'll make if they get a beige garment, they'll make the beige one beige. And then their next one, they'll make it just a slightly darker brown, which allows them to know which is their older ones. So it's another option. With the Confidence, you can also put, it's called a deco line down the front. And that's probably what you saw on that presentation. So it's not a seam or anything. It's just a decorative line. But you can also get it on the arm sleeve, and beyond it being a decorative type of a thing that you can get, it is nice, especially for people that can't see the back of their leg or the outside of their arm to line up their garment correctly, because now there's a line that, and you can't even see, I'm fading out here, but there's a line on the inside that shows you that you're lining up your arm sleeve correctly, because we want the seams to always go on the outside or on the back of your leg. So this line allows you to look down and say, okay, I'm getting it on correctly. I'm donning my garment correctly. So just some fun stuff.
Thank you. Janine would like to know, do you have leggings that are available in 30 to 40 millimeters of mercury of compression, like for workouts and yoga?
No, we do not. I mean, you can get custom, I shouldn't say that. We make custom garments, obviously, and you can make them in whatever you want, leggings and things like that. But if you're looking for like a kind of like Lululemon type under, garments that have compression in it, we don't have those type of a Lycra type garments.
Thank you. Lori would like to know, is there a moisturizer that can be worn under some or all of the Jobst garments?
Well, typically we try and recommend to do your moisturizing before you go to bed. Just because anytime you're adding moisture to your skin, it can make your garments a little bit more difficult to get on. So, if you have the opportunity, and it of course depends on when we all shower, but if you have the opportunity to put your moisture on at night, have that, soak in, and then in the morning, put your garments on, that's the best to go. But we do have, we sell a lotion called Cutimed Acute, and it provides either 3%, 5%, or 10% urea in it, which is a high moisturizing ingredient. So you can use things like that. What I would highly recommend is, if you are looking at your lotion and you're looking at your garment, is to either contact one of us or contact the person who sold you the garment, so that fitter, and just try and see if that lotion is appropriate, because there's a million lotions and I could not possibly list off all the ones that are appropriate or not appropriate. But always, even if you have a lotion that's approved for the garments, if you can do your lotioning before bed instead of before garment, that's always going to be the preferred method.
Thank you. And then the very last question, which, well, actually, no, one just came in. Let me ask this one first. Was the company in North Carolina, what was the company in North Carolina called, or is it a subsidiary of the German makers? I missed that info, sorry.
Oh, no, so we were BSN Medical. So Jobst was bought by BSN Medical about, I guess, probably 15 to 18 years ago. And then we merged, or I should say we were bought by Essity, which is, perhaps you've heard of Tena. It's an incontinence product, or if you've ever been to anywhere and seen Torque or, lots of the paper towels and things like that. That's the company that purchased us. So that's SCA, and its medical division is Essity, which is a combination of essentials and necessity. So that's how they got that name. So we still have our North Carolina based location, and then Essity's location, their their national headquarters is in Philly. So right now we're operating 2. So if you call our customer service, you're most likely talking to somebody in North Carolina still.
Thank you, Katie. And the very last question, which I would like to answer is, well, actually, I'll let you answer too, but then I'll answer as well, is can you discuss how easy these garments are to take on and off, legs especially? To which my answer is, Susan, please tune in on Sunday when I will be demonstrating how to don and doff all of these how to don and doff lower extremity garments with various accessories. So that's our webinar for Sunday, but Katie, would you like to add anything to that?
So, so in regards to how easy or how difficult something is to get on, it's actually a pretty personal question because every single person has reasons why something might be more difficult to get on, whether it be dexterity issues or hand strength or skin issues or something like that. What I can say is that a flat knit garment is going to be significantly easier to get on than an off-the-shelf garment. Because if you think of how circular knit, I say that a lot already to where garments are, it's like a whole bunch of rubber bands or elastic bands in a big tube, right? And so every time you pinch it down, it's one rubber band over one rubber band over one rubber band, and it can be really tight. They also can roll, and that can be really scary if you're in the middle of getting something up and then it rolls down to your ankle and maybe you don't have the dexterity. Flat knit garments are kind of stiff, but not in an unpleasant way. I have a couple pairs and I find them very comfortable, but they are stiff. So you do have, it's almost easier to get that up when you're not worrying about it rolling, when you're not worried about poking your finger through it. I find flat knit garments to be much more easy to get on. And that leads me into our giveaway, which is the Donner. And I know a lot of you raised your hand, but we have phenomenal Ariane Donners, and we make them for both closed toe and open toe. I emphasize closed toe because there seems to never be a good solution for closed toe except for cages, and cages can actually be kind of difficult to use sometimes. So that will make your life a million times easier if you can get something like an Ariane, either Magnite for closed toe or Easy Slide for open toe. So, and somebody here is going to win one. Jeanette, tell us who.
Exactly. Well, that's where we bring Jennifer Williams back onto the scene. So Jennifer, if you can please share your video and share your screen and turn on your mic so that you can tell all of us who the winner is.
Yep. All right, let me share my screen here. All right, here we go.
All right. It's a little bit more dramatic when we have like the clicking sound, but it is Donna. So let's see, let's just make sure that we have her. So Donna, if you can please email Christy Blair, she's at the bottom there. It's christy.blair@lymphnet.org. And she will connect you to SD Jobs. Although, Katie, will it just be you? Should she just take down your email address?
Yeah, you can certainly do that.
Yeah. All right.
Donna, are you in the US?
Let's see, how can we do that? Donna, if you can just put into the chat, if you are in the US. Yes, she is. And
okay,
then, yeah. So then, Katie, if you can just maybe put into the chat for Donna, your email address right now.
Absolutely.
As I conclude and wrap up, I'd like to thank my entire team for all your help. I try to give them a break and, there's the 6 of them, right? And I try to say like, hey, tonight, it's Katie talking, it's Wei talking. So I think I can handle it, but they are so good that they still stuck with me and they all are on and they're still like managing the chat, managing the Q&A, just watching and giving some moral support. So I really appreciate my team. Wei, I think that you might still be on. Let's see, are you still on? No, you're not, you have left. But when you watch this recording, we'd like to thank you again for your amazing talk. We really appreciate you sharing your expertise. And congratulations again to Donna. And we'd like to thank every single one of you who stayed to the very end. I mean, it is a beautiful Friday night here in New York City. I hope that you have wonderful weather wherever you may find yourself as well. But you have all the choices in the world in terms of how you like to spend your Friday night, and you chose to spend it with us, and we're so grateful. And to those of you who will be watching the recording, we hope that you enjoyed this webinar, even though you couldn't participate in the giveaway or in our Q&A and our chat. We hope that to everyone who is watching this, that you found the information valuable and that it will somehow enhance your either self-care or your understanding as it relates to lymphology and lymphedema. So thank you so much. Have a great weekend. You too, Fenton. Have a great weekend. Thanks so much, everyone. Have a great night or morning, wherever you are.